Archie Ong. I'm one of the 4 stroke neurologists at NorthShore. I've been at NorthShore since, well, 2013, I believe. So 8 years. And yeah, I don't know what else to say. I don't know what else you want to know about me, but basically, yeah,
that's a good start.
Yeah, I've been in NorthShore forever, ever since training. And yeah, I'm here to answer your questions and hopefully educate you a little bit more about strokes.
Great. Well, let's start with the basic. Just what is a stroke?
So whenever I get asked that question, I always try to explain that there are 2 different kinds of stroke, and this is just to simplify things. Stroke can be the hemorrhagic kind, meaning it's a bleed inside the head, or the ischemic kind, wherein the brain doesn't get enough oxygen because one of the arteries that supply the brain gets closed. So basically, that's what a stroke is. So an injury to the brain, and the technical definition is even in the spinal cord or the retina. So yeah, those are strokes actually.
And what are the most obvious signs of stroke? And do they differ for men and women? We always try to talk about differences with heart disease for men and women in our meetings.
Correct. So the common symptoms are the ones that you see on the billboards. I think there are some billboards available out there when you're driving on the freeway. But yeah, it's face, arm, speech as the main are the main symptoms, meaning one side facial droop, one side facial numbness. So that's F. A is arms or legs, weakness, numbness, clumsiness. And then S means stands for speech, meaning suddenly you can't talk, you're slurring your words, or even you can't understand people. That's a speech problem. And so we tried to summarize or use the mnemonic FAST. And we add T to the end just to remind people that time is brain, and the sooner you call for help, and we encourage people to call 911 when this happens, because there's only a certain period of time that we have to treat strokes. After 4.5 hours, the medication that we give cannot be given because of increased risk for bleeding, and it's always better to get to the hospital sooner because there's more that we could do. And this is mainly talking about the ischemic strokes. For the bleeds, it's basically the same presentation. The only difference is the management, but just the same. We'd want you to come to the hospital because actually the bleeding kind actually has a higher risk for mortality, meaning if you get it, there's a higher chance of dying from it right then and there. But if you survive it, you have a higher chance of recovery compared to the ischemic kind. But I think I'm making things too complicated. I hope I just simplify the symptoms with FAST. Remember that mnemonic, and I think we should be fine. In terms of differences with women and men, I'm not aware of any differences in terms of presentation. Unlike, with heart attacks, we know that with women it could be atypical. For strokes, it's similar. There's no difference.
Okay. And you already touched on it, but what should be done if those signs appear? It's like get to the hospital as soon as possible, correct?
Correct. Some people, when they read things, they say, oh, maybe I should take an aspirin. I would not encourage that, just because if it is a bleeding kind of stroke, you could make things worse. And so really just go to the hospital as soon as possible is what we recommend.
There's really no way for a person.
Call 911, because if you go to the hospital on your own, you won't get triaged the same way you will if you call 911 and the paramedics bring you in. I've had strokes and I've been to NorthShore for care. So I'm going to tell you now, it's not go to the hospital, call 911.
I agree. That's what we always say, 911. But getting to the hospital in one way, in one form or the other, if you don't want to call 911, is better than waiting it out. Because I believe me, I mean, like I said, I've been doing this for quite a while. You'd be surprised with the amount of people who decide to, oh, I'll just sleep it off, and maybe it would get better. And most of the times, they get worse actually. So better err on the safe side. If you have any of these symptoms, just call 911.
Okay, great advice. Thanks for that comment too from one of our attendees. What about the less obvious signs of stroke? Now, I was reading about this getting ready for the meeting. I saw things like nausea, dizziness, numbness. I mean, we all have, or maybe not all of us, but we sometimes can have those for other reasons too. So how do you know the difference?
Correct. So that's where it makes it a little bit more difficult. I guess that's why I'm still working, and we still do strokes. We still need stroke neurologists. So the main reason why it's atypical is just because of how strokes present. Most of the time, the strokes are in the anterior circulation, meaning the circulation in the front, involving the carotid arteries. But in I believe 10 to 20% of the time, it could be from the posterior circulation, and that's when it makes things more challenging, because the symptoms of a stroke from the back part of the brain is more subtle. So these are the things that you just mentioned, and these are sudden dizziness, with nausea, vomiting, as double vision, loss of vision, and some trouble swallowing. So these are the things that that are the atypical presentations for strokes. Nowadays, instead of just fast, when I educate my patients who've had strokes, or even just patients who I see in clinic, I always just add the BE to the mnemonic that I gave you earlier. Instead of just fast, I tell them be fast, because it makes them aware of the less common symptoms of B, standing for, which stands for balance. So they could become suddenly dizzy, unsteady, and that's B. And then eyes, suddenly they lose vision, or they have double vision. Those are, I would say, glaring symptoms of stroke in the back part of the head that are less common. Now, to answer the other question about how do you differentiate that from, I don't know, just having, feeling under the weather, right? Sometimes people get just some nausea or I don't know, dizziness even, like spinning sensation. So how do you determine whether it's serious or not? Well, I think the simple rule that I would say is, if it's new and you've never had it before, nobody would fault you by calling 911 or going to the ER. If you have this symptom, even though it's not new, let's just say you've had episodes of dizziness in the past, but suddenly there's a component of weakness to it that you've never had. There's a component of loss of vision or double vision with it that you've never had. You're slurring your speech with this usual dizziness that you get. Mm-hmm. Then yes, you have to call 911. So a combination of the unusual symptoms with the usual symptoms definitely should make you worry or make you call 911. I hope that clarified things.
No. Are you seeing people being more reluctant during COVID to go to the emergency room?
During the early parts of the pandemic, definitely we saw a decline in the amount of people going to the ER, and obviously that's not good. But nowadays, nobody's told us that they don't go to the ER because of COVID anymore. It's most of the time the same reasons that people used to tell us pre-COVID, which is, I thought it would go away, kind of situation. So yeah, for a while there it did, but nowadays no.
Okay, well, that's good to hear.
John, I
Go ahead,
had,
Rick. Go ahead.
when I was, before I had the heart valve issue, I had strep pneumonia in 2018, and I actually went to the ER at Skokie Hospital. I ended up in intensive care for 8 days, and they thought I had a stroke. And it turns out that I had meningitis in the brain. I had bacterial pneumonia, meningitis in the brain, and sepsis in the blood. And it got into my heart later, and pneumonia, and at the same time. And I was in ICU for 8 days, 6 days with tubes in my throat and stuff. And when I ended up learning how to walk again because I lost my muscles, they sent me to Evanston Hospital to do that. And then I ended up in a nursing home for 8 weeks with antibiotics in my arm. And they thought that I still had the stroke though. And fortunately, my speech was a little affected, but then it went away. So I didn't have a stroke, and it was healed miraculously. It was good. And I ended up, but it got into my heart, the bacteria. So the stroke wasn't there, but they really thought I had a stroke. They were feeding me. They were cutting my food up even, in the nursing home even at first. And then I got better. I'm here. I said I was in the gym 3 times a week now. I'm grateful. But just that, boy, how do you do that? It's gonna be hard for you to figure out something.
So Rick, yeah, I'm glad that you're with us, talking and in the meeting, because it seems like you went through a lot there. But yeah, that's the tricky thing about stroke. There are other things that can mimic a stroke, and so that's why I always just tell my patients, when in doubt, if you're worried this is different from what you've had before, or you've never had this before, when in doubt, call 911. That's why the ER is there, and that's why I guess we pay insurance, right? So yeah, when in doubt, call 911.
Can I just like to share? I've had 2 strokes, and before my strokes, I had lost my peripheral vision and I had numbness in my fingers and toes. And I told my cardiologist, and he said, "Oh, well, you have a really weak heart, so it's just that your blood vessels, they're too small and your heart can't pump blood there." And it felt wrong to me, but I let it go, and then I had a stroke. And then even though I was on blood thinners, I had a second stroke, which I didn't even know about. So if something doesn't seem right to you, push it. If you have to go to the ER, it's better than having a doctor tell you not to worry about it. And this was back in 2011. What I understand now is that if you present any signs that are stroke-like, they at least do a stroke workup for you. And your chances are better than mine of avoiding it.
Is that true, doctor? Has the response changed when people come in?
I would say the interventions that we can do there's more interventions that we could do. Let's just put it that way. Aside from the medication, we can now try to open up any closed blood vessels inside the head. So it's just like with the heart. They go in there, they either angioplasty it or they stent the blood vessel in the heart. That can be done in the brain nowadays. Not necessarily stenting it, but trying to take the clot away. That can be done nowadays. So yes, that's one of the main differences from 2011 to now.
Wow. So just in the last 10 years, that's come into practice?
Right. Because even in 2011, that's when all these trials were coming out. But I think the devices that they were using back then were inferior to the ones that are available now. And that's why the studies back then actually were saying that these intra-arterial interventions are not better than just getting TPA. But with the newer technology, with the newer stent retrievers that are out there, it's been proven that thrombectomies or intra-arterial interventions, when given to the right people at the right time, improve better or really get great improvement from it compared to just getting TPA or getting nothing at all. Yeah.
That's a good segue into treatment, which is our next question. Like, what sort of treatments are there now? Oh, we have a question here too.
Right. So yeah, I see the chat box there. But to answer your question, so the treatment for stroke that's come in acutely are two things. And again, I'm talking about ischemic strokes. With bleeds, it's all about supportive management. We need to control that blood pressure, make sure the bleeding inside the head doesn't get any bigger. And if you're on any blood thinners, especially with the group here, I'm with the cardiology support group, so I would assume that some of you are on any on blood thinners. So if somebody bleeds inside the head, the main thing we do is to stop that medication, reverse that medication, make sure the bleeding doesn't get bigger. But on the flip side, for ischemic strokes, the interventions we can do is still the clot busting medication called alteplase, and we give that through the vein, and we can only give that up to 4.5 hours. After that, the other intervention that we may be able to offer is the intra-arterial mechanical thrombectomy, wherein we put a wire through the groin or through the wrist and get the wire all the way up to the head and get that clot out of the blood vessel. So those are the two main interventions that we could do for ischemic strokes.
And that second one is the newer process you were talking about?
Correct. Correct.
And does that address the question that this person asked?
I don't think the question by Mary has been answered. So let me answer her question. Her question is, can you talk a little about TIAs versus strokes and some of the causes and symptoms? I touched on the symptoms already. The causes, definitely I can discuss that. So the main difference between
what TIA is first, Doctor. Can you just say what does TIA stand for?
Correct. So TIA stands for transient ischemic attack. The way I describe this to patients is it's basically a stroke that doesn't last long enough to cause permanent clinical symptoms, and also doesn't cause any permanent injury to the brain that we can see on a scan. So that's how I define TIA. Usually TIAs last for a couple of hours to less than 24 hours. By definition, that's what we try to follow. And that's the main difference between a TIA and a stroke. A stroke lasts longer than 24 hours and you see something on the scans, versus a TIA, usually less than 24 hours and you don't see anything on the scan. As for the causes, the causes for strokes and TIAs are actually the same. And again, I'm simplifying it because when I say stroke here, I'm talking about ischemic strokes. For bleeding strokes, the reasons are not exactly the same. So just for TIA and ischemic stroke, the causes can be simplified into, I would say, 3. One would be from plaque buildup, meaning the blood vessels get smaller and smaller because of plaque buildup, and eventually it closes completely, and that's one of the reasons why you can get a stroke. Plaque buildup happens when your risk factors for stroke are not controlled. And what are the risk factors for stroke? It's basically the same risk factors for heart attack. So high blood pressure, diabetes, high cholesterol, and that's just the most common reasons. And so so that's one of the reasons for a stroke or a TIA. Other reason would be cardiogenic or cardioembolic. That's a fancy term to mean that a clot most likely traveled from the heart and went up to the brain. And that's most commonly associated with irregular heartbeats like atrial fibrillation or atrial flutter. That is, I would say, the second possible reason for stroke. And then the third would be more for younger people if they have blood problems that predispose them to forming clots. So I would say that's the three common reasons why people can get strokes.
Yeah, there's a second question in the chat box, if you can see that.
Correct. So from Marla, she says, is a vertebral artery dissection considered a stroke? Is it a common occurrence? So I guess it's best for me to define what vertebral artery dissection is first. So a vertebral artery dissection basically means that the artery, let me backtrack a little bit by giving you a little bit of a lesson in anatomy. So the arteries that we all have layers to it. And when a dissection happens, the innermost layer peels off. So imagine instead of having a round pipe for your blood vessels, when the inner layer peels off, the pipe can get closed or can suddenly narrow because of that false flap or because of that inner layer that opened up. Vertebral artery dissection per se is not considered a stroke, but it is one possible reason for a stroke. Is it a common occurrence? I'm biased because all my patients are stroke patients, so I see it fairly commonly, but it's more common in younger people. Let's just put it that way. I don't have an exact figure as to how common it is, but yes, I see a lot of it in my practice. I hope that answers your question, Marla.
Is that what SCAD is? I have a friend who's suffered with that, where she's had 2 artery dissections from, I think the first one when she was in her 30s, and now another one more recently. That's what the AD and those initials stands for, isn't it? Arterial dissection.
Correct. Correct. So depending on what artery gets dissected, it could be internal carotid artery dissection versus vertebral artery dissection. So yeah, so there are different, I guess, acronyms that people could use.
Right. And there's still not a lot of research on what causes that dissection.
So the dissections, they occur spontaneously in some people. Actually, in most people. The other common reason would be trauma. So whiplash injuries, getting into car accidents like that, or sometimes neck manipulations, although chiropractors most likely would disagree with what I say. But yeah, basically any jarring movement to the head that's high impact can cause dissections. Even, in fact, as simple as coughing, forceful coughing can cause dissections in some people. I'm not trying to scare anybody here. I mean, but I'm just telling you
the rest of the night.
But that can cause it. But like I said, the most common reason is no reason at all. It just happens. And the thing that gives us a clue as to whether this is the reason for the stroke is most of the time this is accompanied by pain. So you either have a neck pain or a pain in your eye when you get dissections with strokes, or just pain. So I guess that's one of the things that I should have mentioned earlier too, in terms of less common reasons for stroke would be headache. Any new headache, I think, needs to be evaluated by at least your primary physician if it's not severe. But if it's severe, the worst headache of your life, even if you don't have any other symptoms, call 911. Could be a bleed. Okay.
Someone asked a question in the chat about COVID and stroke. Can COVID cause strokes?
Unfortunately, yes. There are now a lot of studies or literature out there that says that COVID really increases your risk for stroke. In fact, any kind of infection can increase your risk for stroke. But COVID per se, yes, just because for some reason the virus makes your blood thick. And so when somebody gets COVID, actually that's one of the things that gets checked to see if your blood is, there's a high predisposition for you to form clots, and some people do get placed on a blood thinner preemptively, just to prevent not just strokes, but blood clots in the legs and in the lungs.
And is that even if it's a mild case of COVID, or is there any?
Oh no, usually these are for the severe ones.
Okay.
But yes, it can happen, especially in younger people. That's my experience. Younger people who have no reason to have a stroke, and we usually check for COVID in those situations, because could it be that COVID, infected that patient, and he or she didn't know about it. Because I said earlier, usually it's severe, yes, because they're already in the hospital, but sometimes we catch it when they're not yet that severe, and the first time they have a fever is when they're in the hospital after the stroke. So I guess I would encourage everybody to get their vaccines.
Let's talk about preventive measures to prevent strokes. I mean, you mentioned blood thinners. I'm on a blood thinner. I have AFib, and although I have to say, when I first went to the warfarin clinic and they talked about, well, you could bleed in your head, that got my attention. What you were talking about earlier. So I try to have 2 pillows every night in bed. But what is that the most common preventative measure to put people on blood thinners, or are there other things that are done as well?
So it really depends on what caused the stroke. If the stroke is from plaque buildup, like I mentioned earlier, usually aspirin with a combination of your cholesterol lowering drugs and controlling your blood pressure and your blood sugar is good enough. You don't need to be on a strong blood thinner. It's when the stroke is from atrial fibrillation, atrial flutter, or the blood problems that I mentioned. That's when people need to be on a strong blood thinner like warfarin or any of these newer drugs that you hear on TV, the apixaban, rivaroxaban, edoxaban, and the bigatran. So, but yeah, not everybody needs to be on that in terms of stroke prevention. And I guess let me clarify that too. I answered that in terms of secondary prevention, meaning preventing strokes in people who've already had a stroke or a heart attack. Okay. We also try to emphasize the importance of primary prevention, and that's basically just living a healthy life, controlling your risk factors, exercising, eating a healthy diet, and avoiding smoking. Don't drink too much, and yeah, maybe visit your primary physician at least every year is what I would suggest. And even after a stroke, we highly encourage these non-pharmacologic interventions. We encourage people to exercise, just like heart patients, heart attack patients, or we encourage exercise, diet, and all these non-pharmacologic interventions.
It always comes back to being healthy, doesn't it? Eating healthy, not eating junk food, not doing all the things Americans typically do.
That's true. Actually, that's the hard part, right? I always tell my patients, it's easy to take the medications. Most of the time, it's the lifestyle change that's harder. But I think it's worth it, especially the potential long-term effects of a stroke. You'd really want to prevent that.
The new treatments you mentioned, are you seeing more people get back to normal life after strokes? I mean, when I was a small child, my grandmother had a series of strokes. She had trouble walking. She had trouble talking, and that just seemed like her life for those last few years of her life. I mean, are more people recovering full sort of everyday functioning now, or?
It really still depends on the amount of injury to the brain that the stroke caused. If it's a big stroke, not to be a defeatist, but no amount of therapy would get you back to 100%. I would say. Would you be able to get to a point where maybe you could be left at home and be independent? Yes, in certain cases. Sadly, the in the realm of neuro or stroke rehabilitation, there's not been too many improvements. Let's just put it that way. It's hard. We can't regrow brain, which is the main problem, and we only have one. So really, that's why we preach prevention. Really, I don't believe that the recovery is better now than it was before. The only thing.
Go ahead, Maureen.
That's actually not true, because when I had my stroke in 2011, I had to wait for heart transplant. So I didn't do any rehab for 2 years. And I was told then that I would not get any better. And I couldn't walk on my own. And I went to Shirley Ryan, which was in the Rehab Institute, and I did intensive rehab and I walk on my own. And what they now are saying is that the brain neuroplasticity is really long-term, and that, so now the theory of, I'm sorry, I also run a stroke group, is that if you continue to work on rehabbing, you will improve. And this is something that they didn't believe a couple of years ago. So the big change in stroke is that they're trying to tell you to always work on it because you can improve.
Okay, I guess that's why I was trying to be careful with what I was saying there, especially when people come to me for about rehab. I always tell them that yes, you should continue to exercise, keep doing therapies if you can, if it's covered by insurance, go. If not, keep doing the home exercises, because yes, there is improvement, but incremental. I would argue there's less people who make big improvements like you did, Maureen. I'm glad that you did, but most of the time, especially if they've had big strokes, the improvement after a stroke, after a year or two, is definitely less compared to the first 6 months from the time you had the stroke. So yeah, I just want to clarify that. I'm not saying that people shouldn't get therapy. In fact, I encourage that. It's just, I also want to, I always try to set realistic goals for the patient. And yeah, I hope that clarifies that.
There's another question in the chat. Can you see that, Doctor?
Yes. I understand TPA can only be given within a 60-minute time frame. What happens if you don't get to the hospital in 60 minutes? That is the short window. So Marla, that information is incorrect. Like I said earlier, we can give the TPA up to 4.5 hours from the last time the patient is normal. So the 60 minutes that you're talking about is more for us, the physicians. There are certain, what do we call this? Certain entities like the Joint Commission who look at our performance, and we always try to get it within 60 minutes from the time somebody gets into the door, if we're going to give TPA. I think that's what you mean, Marla.
List. Well, unless there's anything you want to tell me, you can just talk.
Another question there. If everyone else can mute themselves when they're not talking, please.
So the next question is, are you seeing neurological symptoms after the COVID vaccine or only associated with the illness? Neurological symptoms, yes, I have seen after the vaccine, not necessarily strokes. There are numerous reports of neurologic symptoms after the COVID vaccine, unfortunately. But still, based on the grand rounds that I attended that was given to us by my colleagues, they said that based on the available literature, even though there's possible neurologic side effects from the COVID vaccine, the amount of side effects when you pool all the people who received the vaccine, though, is still significantly less compared to the benefits that one might receive from the vaccine. I hope I answered your question.
I have another point here. My doctor said, because I have blood clotting disorder, that if I was worried about the neurological effects of the vaccine, I should be more worried about the neurological effects of COVID. Because if the vaccine gave me neurological effects, getting COVID would give me worse neurological effects. So I just wanted to add that.
Thank you, Marie. Doctor, what does that mean? What are neurological effects?
So, well, let me see. I guess neurological effects would be, because the question was neurological symptoms. So
okay. Well, what are those?
it's varied. Let's just put it that way. After the vaccine, there have been some reports of like neuropathic symptoms wherein you get some numbness. Some people have reported mostly non-specific symptoms like that. That's why I can't quite explain it that well. And I'm going to tell you now, I'm not an expert in the COVID vaccine side effects. Although from a stroke standpoint, all I could say is, yes, I have some patients who've presented with the stroke after they've received the vaccine. Do we blame it on that? Most of the time, we find other reasons before we blame it on the vaccine. And I don't think I've seen any patient who I can really blame the vaccine as the cause for their stroke. Let's just put it that way. Yeah.
Are there other questions from the audience? I think we've gone through our prepared list. Do we have other people on the call who've survived strokes? Strokes run in my mother's family. Heart attacks are in my father's family. That's why I'm in Mended Hearts. I've had 2 stents put in. No strokes yet, though.
Well, I hope it never happens. I think, like I said, what's good for the heart is good for the brain. So if people are doing the right things for the heart, hopefully that should prevent strokes too.
So
So there's a next question here from.
Yeah. Why don't you answer the question first, Rick? Why don't you hold on a second?
No.
Let him answer the question.
So Carolyn asks, are heart patients at higher risk for strokes compared to non-heart patients? The short answer is yes. So most of the time, and I guess I would define what I believe you mean by heart patients. So heart patients meaning patients who've had heart attacks, patients who have atrial fibrillation or atrial flutter. The answer is yes, no doubt. Just like previous stroke is higher, puts you at higher risk for having another stroke. Same thing, having a heart attack puts you at higher risk of having another stroke. And atrial fibrillation, if you're not on a blood thinner, puts you at a 5 times higher risk of having a stroke. So yes, definitely. That's why I was happy to give this talk to your group, because there is definitely a heart-brain correlation, and yeah. So the short answer is yes.
Go ahead, Rick. What were you going to say? I'll unmute you.
You need a mended brain group, right? No.
Yeah.
I forgot exactly what I was thinking about. I had a little of each, the bacteria and the heart, both. And right now I have no. I'm on little aspirin, baby aspirin now. That's all, and no water pill, nothing else. It took me totally off of it. So I'm still okay with the baby aspirin. Is that good for the stress for the brain too, right? You said.
So with regards to aspirin, so if you've not had any heart attacks, you've not had any strokes or any vascular problem, I actually don't suggest people to take aspirin. That's an old recommendation, and that's been changed now.
The cardiologist insists I stay on it. I'm still getting some bumps, red spots on me, just with that.
Right. I mean, you are in the Mended Hearts group here, so I assume you have some heart issues. So definitely don't stop your aspirin. I'm talking about those patients who've never had any heart attacks, never had any heart issues, never had any strokes or vascular issues that are taking aspirin. We don't suggest aspirin anymore in healthy people, because back then, primary physicians would start patients on aspirin just based on age. When they reach a certain age, they say, "Oh, why don't you take some aspirin?" That's not the recommendations anymore.
There was a lot of marketing behind that too, wasn't there, by the aspirin makers?
I will take the fifth on that. I don't know.
Okay. When you were talking about AFib and strokes, I was thinking of one of the things that comes up, as I said, I have AFib, is that you can have a procedure done to close some little chamber in your heart where the blood collects. Is that out of your area, or can you address like the effectiveness of doing that as well?
Definitely. So what you're pertaining to is, I believe, the left atrial appendage occlusion device. Mm-hmm. I think it's more commonly known by the name of the device called the Watchman. Mm-hmm. So yes, it's a device that gets placed in the left upper chamber of the heart. There's like an appendage in that chamber where clots form in people who have atrial fibrillation and atrial flutter. And that device closes that appendage, and patients who have AFib or atrial flutter can potentially come off blood thinners once this device is successfully placed. We don't suggest this to everybody, though. It's not our first line treatment for people with atrial fibrillation and atrial flutter, because it's still an intervention. It's still a surgery. And we only suggest this intervention in people who have atrial fibrillation, need to be off a blood thinner permanently. For example, somebody who has AFib develops bleeding from diverticulitis, and they can't take blood thinner because every time they do, they start losing blood, and diverticulitis can't be fixed that easily either. You need to get either a colectomy or something surgical like that. So in those situations, we can advise them to get this device.
All right, anyone else have any other questions?
I just want to say,
Go ahead, Lynn.
I was on baby aspirin and I had a doctor that told me the exact same thing. You're healthy, you've never had a heart attack or a stroke or anything go off. But I told this doctor, I knew I had a blood clotting disorder. So my big thing is know your risk factors. Like I should have stayed on the baby aspirin, now I'm on warfarin because I have a blood clotting disorder. So like Rick, you need to make sure that, ask your doctor why you're on the aspirin. Is it because they think you have a higher risk for clots? Because that's where the aspirin is protecting you. So, or could be protecting you. Before you go off, just ask them why you're on it.
Yeah, that's a great point. I actually am on 2 blood thinners and not the aspirin because the aspirin was bothering my stomach. So
I wouldn't do it on my own anyway.
I take warfarin and another blood thinner, and every time I go to pick up that second blood thinner at the pharmacy, they say, "No one takes this with warfarin." I said, "Yeah, I do," because I'm not taking the aspirin. My doctor and I have discussed this. I know exactly what I'm doing. So
all the different blood thinners act, in different ways. So you can take a number of them, but and they're not, they're all classified as blood thinners, but some may be antiplatelet medications, some may be anti-protein medications. So again, Rick, I agree. Talk with your cardiologist and your physicians before you start switching things up. Or
I haven't done that, but I asked, and he said, I'm showing him, I'm getting the bumps on my skin because my blood's thinner, and I do eat salad and stuff, but I'm not on warfarin or anything anymore, but I'm still getting those bumps. And he said, it's worth it because just with the little aspirin is okay. It's worth the risk, like you said, the balance.
Doctor, there's another question in the chat room as well.
Right. Yeah. So let me answer that question. But before I answer that question, I want to put a disclaimer here with what I said there. Please don't. Anybody here in this group, don't just change your medication or stop your aspirin or stop your Plavix or ticagrelor without letting your doctors know. I don't know your medical histories. Don't change your medications without talking to your doctors. Okay. Now, to answer the question from Mary Ann, is there any association between multiple sclerosis and stroke, or multiple sclerosis and the COVID vaccine, or the illness itself? So many questions there. So MS and stroke, there's no association. With MS and the COVID vaccine, I do believe there are some reports of I would put it this way: the vaccine, you need to talk to your MS physician, just because the medication that you are taking for your MS may need to be held before the vaccine. But is there, a cause and effect of receiving the vaccine and getting MS? I'm not aware of that.
Okay. Does that answer your question? So who asked that, Marianne? Yes. Okay, great. Any final questions? We're coming to the end of our hour here. Anybody else? As you see, Doctor, we're a very lively group. So
I like it. I like the questions. So yeah, I appreciate everybody to listen, attending.
We really
Thank you
appreciate
very
having you.
much.
Thank you so much. And there's some
If anybody does have any other questions about medications or things, certainly, send me or John a note. And there is a group of pharmacists and pharmacy residents who would love to do some kind of breakout sessions sometimes to talk about specific medications, whether they be anticoagulation, antiarrhythmics. So if you guys are interested in that, we can certainly set that up kind of as an offshoot, a different day than our second Tuesday meetings.
Yeah, that's a great point. Thank you, Debbie. And before this meeting, Debbie and I were just planning next year's topics, and we were saying we can add, since we're doing everything online, we could always add a second meeting in a given month if
Sure.
people have a topic they really want to delve into in more detail.
And hopefully sometime next year we'll be able to meet in person.
Yes, that would be nice. All right, thank you all very much. I apologize again for my early technical problems, but we got it all together here, and I think it worked out pretty well. Thank you again, Dr. Ong. It was great to have you. And thanks to everyone
my
for
pleasure.
coming. We had 18 people here today. That's a great turnout. Thank you, everyone. Good night.
All right,
Good
bye-bye.
night. Bye-bye.